Доброго вечора, українські радіаційні онкологи, медичні фізики, радіаційні терапевтичні технологи. Слава Україні! Дуже дякуємо, що приєдналися до SBRT SRS course with Austro APM experts for Ukraine. Help Ukraine Group, Austro International Committee, APM Clinical Education Subcommittee, Rise Contra Cancer with SweetCare support. We are all excited to present the fifth lecture in the course, and the topic is bone SBRT. We have a team of amazing speakers, radiation oncologists, medical physicists, RTT from Sunnybrook Odette Cancer Center in Canada. So their names are Arjun, Saghal, Saher Ali, and Renee Korol. Professor Arjun Saghal is an international clinical and research leader in the field of high-precision stereotactic radiation to the brain and spine for both MATs and primary tumors. He currently serves as the chief of the Department of Radiation Oncology, University of Toronto, affiliated Sunnybrook Odette Cancer Center. Since his radiation oncology training at University of Toronto and radiosurgery fellowship at University of California, San Francisco, he has published over 700 peer-reviewed papers, which is very impressive. I don't know how it's insanely possible. And these papers included high-impact journals like Journal of Clinical Oncology, Lancet Oncology, New England Journal of Medicine, and 40 international guidelines specific to SRS and SBRT. He's given over 200 lectures as an invited international speaker. He invented 24 gray in 2 SBRT fraction regimen for spinal mats, which was tested in his landmark international CCTG SC24 randomized trial, providing superiority over conventional palliative radiation. He's been instrumental in raising a total of 50 million in grant and philanthropic funding to support central nervous system research at Sunnybrook. In addition to leading several international research consortia, he's served as co-chairperson of the AO Spine Tumor Knowledge Forum, currently the president of International Stereotactic Radiosurgery Society. His next phase of research is development of a MAR-LINAC adaptive RT and integration of functional imaging sequences for GBM, CT adaptive radiotherapy, automated vertebral fracture risk prediction, and he leads the ongoing Canadian randomized trial of SBRT versus conventional radiation for non-spine bone mats. He has been awarded several national and international recognitions, including the King Charles III Coronation Medal. Congratulations, that's a very impressive resume. And next speaker, we have Saher Ali. She's a clinical specialist radiation therapist at the Odette Cancer Center, where she leads the SBRT program. She plays a key role in protocol development, interprofessional education, and clinical oversight to ensure safe and consistent SBRT delivery. With a hands-on approach, she bridges the gap between therapists, physicists, physicians, supporting integrated patient-centered care. And Dr. Renee Korol with us is the lead physicist for stereotactic body radiation therapy program and external beam treatment planning at Odette Cancer Center. Her research interests span from assessing different treatment planning strategies to target localization for SBRT patients with a special interest in GI and oligomats. This includes the assessment of PTV margins, organ motion, and impact of various immobilization devices. Thank you so much for preparing this lecture today. We are very excited and looking forward to learning from you. So the topic is bone SBRT, and the podium is yours. So I'll stop sharing.
Okay, wonderful. Okay, let me just get set up here and then we can start. I think we're in presenter view right now. Is that okay?
Excellent, yes.
Okay, perfect. Well, listen, it's a real pleasure to speak to you today and to share the knowledge that we've accumulated as a team here at Sunnybrook and a lot of radiation oncologists in Canada to develop the field of spine and non-spine bone metastases. So it is a sincere honor to do so. Just my disclosures. Okay, so let's start with spine because I understand that's a main focus for this discussion. And when we started spine SBRT, a lot of people asked, why are you doing this? Well, when we looked at the doses that were traditionally given with conventional radiation, they're relatively low BED. However, when you increase the dose using a stereotactic distribution, you really accelerate the biologic equivalent dose that's delivered. But moreover, in a stereotactic distribution, and that heterogeneity of the dose distribution is in itself very unique and driving response. And we argued that there'd be better rates of pain control and local control. So what were doses given? Well, I learned 24 and 3 when I was in San Francisco. Sloan Kettering came along with 24 and 1, but we found that there was increased risk of fracture. And at that point I said, well, look, let's find something in the middle, 24 and 2. We came up with all the dose limits, and away we went in terms of delivering this treatment. But how do we deliver it? And this is what's important. You really have to apply the technological limits in order to provide safe treatment. And this is work that we did many years ago, and Renee was one of our physicists also on this analysis. But this was a long time ago, and technology has changed. We still argue for near rigid body immobilization, in particular if you don't have stereoscopic imaging like a brain lab system. If you do, I think you could probably avoid using such rigid immobilization, but you still need MR simulation, CT simulation, thin slice, using IMRT or VMAT, sub-centimeter MLCs, and image guidance. And our image guidance protocol is such that we apply 6 degrees of freedom correction with a robotic couch top, and our threshold is 1 millimeter and 1 degree. So when we did all this, and this was on the days where there was 400 monitor units per minute of output. So we really started imaging people many times during treatment, and we're able to determine our intrafraction motion confidence with 95% certainty of 1.2 millimeters and 0.9 degrees. Moreover, we also found that if your time limit exceeds 20 minutes, you have to repeat the cone beam. Nowadays with FFF and VMAT, it's not an issue because the dose rates are so fast that we never exceed 20 minutes. Okay, so how do we do it? And this is the principles of contouring, the clinical target volume. So we don't treat the GTV, we treat a CTV. And many of us got together early on in the days and then drew what we were doing because there were so few people doing spine SBRT, and we came up with consensus guidelines, and we all sat in New York at Sloan Kettering. But this is expert, but does it matter? And this is work from Kristen Redmond at Johns Hopkins showing if you deviate from these contouring consensus guidelines, you actually impact local control. So follow the guideline. And this is internationally recognized with data to now back it up. Now, one of the areas of controversy is the sacrum. And here, many people argue that it's a non-spine. But we applied the same principles of spine and treat it that way, even though there's no intervertebral disc. There is a bony fusion plate, and we respect that when you talk about S1 versus S2, et cetera. And we applied the principles of anatomy and taking an anatomic region at risk like we do with the mobile spine. So we came up with some anatomical guidelines based on, again, expert consensus. And a lot of people said, well, look, this is a lot, in terms of how much bone you're radiating. But we were able to prove that if you under contour, your actually rates of local control are worse than if you respect the contouring guidelines. So again, more data showing that an anatomic CTV is relevant. Now, this is an example of how complex these sacral metastases are. This is a patient with a sacral hemangioparasitoma met that we treated with 40 grain 5 fractions. You can see here the GTV. You see this darkening of the bone, and that's tumor infiltration. It's very hard to understand where the tumor is on an MRI as well. So that's one of the limitations and why you apply CTV. So we're at S1. We applied our principles of treating the adjacent bony compartment. And there she is now in terms of tumor progression. About 2 years later, you can see now here there's disease infiltration where there wasn't before, even though we treated it. and failing inferiorly as you go down the sacrum. And that's why you always have to take the compartments above and below, but there's some bad actors that are going to fail. And if we only treated GTV, she may have failed much sooner. Now, there are other anatomic regions that you have to think about beyond the bone. And one of these is paraspinal disease and epidural disease. So this is when there's soft tissue extension beyond the bone. You can see here, or in the soft tissues, along the paraspinal musculature, big paraspinal mass. And then epidural disease. So a little bit of epidural disease encroaching on the sacral canal, involving the neural foramen, epidural disease here. And these are distinct entities. And this is what we've proven over time. So let's start with our first multiple choice question. Based on what I've shown you, which practice has the highest rate of failure for vertebral bone metastases involving the ipsilateral pedicle? If you just treat the GTV, if you treat the entire CTV, vertebral body and ipsilateral pedicle, or if your CTV involves the entire vertebral body, ipsilateral pedicle, and transverse process. So which one would have the worst rate of failure? And I think we're all seeing GTV alone. Absolutely. Now, which one has the least amount of failure is C. So if you're going to take the posterior element and the pedicle is involved, take the entire posterior element. And that's the principle of the guideline. Okay. So now we get into cord contouring, because one of the fears initially was causing radiation myelitis. And I tell people when I started, I used to dictate like a half a page on risk of radiation myelopathy. Now it's one line, under 1%. And I'll tell you why. Well, number one, we figured out our practice. You can contour the cord. You can add a 1.5 millimeter margin for PRV, or you can take the sac. Early days, we took the sac because we couldn't fuse properly. Now we apply 1.5 millimeter PRV because, again, there's some cord motion, there's uncertainty in the cord contouring, and it gives you a safety margin. And this has been now widespread practice. Now, below where there's no cord, that's when you take the thecal sac. So you use, say, your T2 or your T1. You don't take the neural foramens or the fat involving the neural foramen. You take the thecal sac, and the nerve roots are dancing in there. So it's not good enough, in my opinion, to take just the nerve roots. And as you traverse down into the canal where the cauda CSF ends, well, you're in fat with nerve roots. So use your peripheral nerve roots to guide where you draw your thecal sac. But you have to limit this because there are many nerve roots that control urine and bladder and bowel that are important, that live there. So what are the constraints? Well, we did a lot of work over the years, and ultimately it's culminated to the high-tech analysis. So we looked at all the data, and this is my practice. So when I don't have to take a lot of risk, we use 18.7 and 2 for 2 fractions. When we do need to take some risk, like epidural disease, 19.3 gray, and that's based on this upper limit of the probability, where you're taking a little bit of risk of radiation myelitis, under 5% as opposed to under 1%. And these numbers have been robust. Now, what happens if you don't listen to these numbers, right? And this is what happened with Sloan Kettering. So they reported on 30 cases of radiation myelitis. I mean, it's an astounding number, and they were able to model their data, so it's great data. And what they found was that if your cord D max is about 20 gray and 3 fractions, and that's to the true cord, your risk of myelitis is really quite low. So there's a range. They treated well beyond that. And it just tells you if you ignore the principles, you're going to cause harm. And there's no magic in this. The cord is primarily an organ in series. There is some parallel component, but it's not a peripheral nerve root. And this proves it, that if you ignore the work that we did many years ago, you know 30 people didn't necessarily have to get radiation myelitis, and that's a significant complication that we've only caused one case out of about 2,800. Okay, what about reirradiation? Well, this is a much more challenging area. This is work that I did many years ago, and there's really nothing since. And we've upped our doses over the years as we feel more comfortable. We're writing up our dose escalation series and reirradiation. But ultimately, if you've got a lot of previous radiation, yeah, EQD2 of 50, drop the dose down. But otherwise, we follow these numbers pretty much to a T, and we've been pretty good. So we are writing it up, but these are the numbers that I follow. Okay, so let's go to our next question. Does the spinal cord tolerance data support the organ at risk as organ at risk arranged in series, organ at risk arranged in parallel, or is this mixed, series and parallel? Let's see what we got.
Let's wait a little bit until approximately 80% answers.
All right. It's a tough question.
It is, but you kind of hinted.
Yeah.
MSK, so recently they gave us a lecture on treatment planning, and they said that they are using milligrams for defining the cord. Do you do that also at Sunnybrook?
Yeah, so I haven't used a myelogram in about 15 years, and you
Okay.
don't need, and their practice has changed also. So
Uh-huh.
they use a lot more MR fusion,
Mm-hmm.
but I think you don't need it if you have a solid MRI,
Mm-hmm.
thin slice, and you've got
Good
good fusion,
fusion. Mm-hmm.
you're fine. You don't need
Okay.
it. It's
Yep.
absolutely not needed. And moreover, the window leveling that you use for a myelogram can dramatically change
Mm-hmm.
what the cord you draw is. So I don't find it useful even in post-instrument, but there you could make some argument. Okay, so what do we see? It's an organ in series. And I think that's the way you have to take it at the end of the day. There is a little bit of parallel component, but we just don't know how much.
Mm-hmm.
Okay,
Sounds good.
so let's get to the data. What are the randomized trials to show it's superior? Because we can do all this. You're taking some risk of hurting patients, but very low risk. And what are the data? So the first randomized study was really done by the German group, looking at 24-1 versus 30-10, and it was a sample size of convenience. But it showed what we wanted, 40% complete response rate after 3 months versus 18% or 17%. By 6 months, it's 50% versus 10%. So these were good data to base sample size, but they saw a lot of fractures, 28% with 24-1. And that's why the majority of the world has abandoned 24-1 because it's just too risky on the fracture. If you've got a situation where you've stabilized the patient already, maybe it's okay because you've already done a stabilization, but you are taking risk. So let's get to a randomized study. So this is the SC24 phase 2-3 trial, 24-2 versus 20-5. This was the study we did with Canada, and the Australians came in and helped us out. But ultimately, what we did was we picked the painful vertebra. We said, okay, that's the vertebra that we're going to track. We allowed up to 3 vertebrae in the target volume because many patients have multiple tumors. And we randomized to 24-2 versus 20-5. The primary endpoint was complete response rate at 3 months. And that's a clean endpoint because after that, things are changing oncologically with the medicines. You don't know if it's your treatment still doing it. But by 3 months, the maximal effect of the radiotherapy is had, and you can determine if your treatment has any benefit. So we randomized 229 patients. The majority were breast, lung, and prostate, no surprise. Therefore, the majority were radiosensitive. And what's important is, remember I showed you the epidural and the paraspinal. We call this mass type tumor because it's got soft tissue. So the majority were mass type, which have a more aggressive biology, which is good because that's the kind of patient we choose. And we excluded patients who were frankly unstable, and we used a SIN score. So there was a good balance between stable and potentially unstable. So what were our data? Well, at 3 months, we showed improved complete response rate for pain, 35% with stereotactic, 14% with conventional, and it sustained itself at 3 months. So that's excellent. It's a 21% improvement in complete response rate for pain. 1 in 5 patients will now have no pain as opposed to 1 in 10. So one of the questions people ask is, okay, well, what happened with the long term? Because initially they were concentrated on the short term, but what happened in the long term? Well, we followed our patients, and we have randomized 137 patients on this trial. And so we were able to follow them with long-term MRI because we follow everybody. And then we were able to report mature results for local control. So what we see is the incidence of local failure is higher with conventional radiation as compared to stereotactic. But still, if you had mass type tumor, you do worse, whether or not it's conventional or stereotactic. You do better with stereotactic, but it's still a risk factor. You have less reirradiation as a result of stereotactic because you have less failures, right? And so these are the numbers over here, and the fracture rate was the same. So now we're showing both long-term, short-term. But why was the fracture rate the same? Because we gave more dose. And that's where you have to look at the details. So if you look at the details of the severity of the fracture, and if you look at the iatrogenic fractures, so these are the fractures caused by the radiation as opposed to failure resulting with concurrent tumor progression, weakening the bone, you get grade 3 events, which you don't see otherwise. And that's important. So your treatment is being effective. You are wiping out the tumor, you are weakening the bone, and you get more severe fractures when you fracture. But the incidence is similar, but it's still a low risk. So let's look at some of the personalization, so the impact of histology. So this is some interesting work we did looking at radioresistant, typical radioresistant primaries, and we show that rates of failure are greater than prostate, but still pretty good. You know, you're looking at 80% local control. But what was happening here in the prostate? Because I didn't expect that. So when we looked at those with castrate-resistant prostate cancer as opposed to hormone-sensitive, that was driving up the failure rate. And over time, they will actually achieve a radioresistant histology. So really quite interesting. So we routinely try and be more aggressive on castrate-resistant and less aggressive on hormone-sensitive. But how do we be more aggressive? Well, this is work that Scott Soltis at Stanford did with us and in the high-tech group, and we modeled is there a role for dose escalation? And is there a TCP? And what we found, let's say 2 fractions, if I go to 28 gray, we're going to get 90% local control as opposed to 80%, which is what we're seeing with 24 and 2 at 2 years. Now, I had already escalated the dose many years before because we wanted to get to that higher level. And that's why we're able to report our 28 versus 24 data. So this is dose escalation, retrospective, consecutive case series. What do we see? We see better local control with 28 versus 24. We match the TCP beautifully, and the fracture rates are the same. And I'll show you why in some time. And still, epidural and radioresistant and paraspinal disease were a marker of failure. So it just shows you we still have some room to grow, but we're doing pretty damn good. Now, if you look at other cases where we don't feel comfortable giving 2 fractions because sometimes the volumes are big, you're treating multiple levels, and you're just, you're not sure. And even for me. And so this is where we try and reduce the chance of late effects because the proportion of risk associated with late effects is proportional to your dose per fraction. And that's why we fractionate more. Now, we adopted 30 gray and 4 fractions. These are our data. Good local control at 2 years, fracture risk 10%. And for smaller volumes, we actually showed that we achieved no fracture. Now, we don't know what the impact of reducing the dose per fraction is, truthfully, on reducing risk of fracture, but we have some sense of it. But this is what you do to try and reduce risk overall. Now, how do we select these patients properly? And this is where you have to understand the risk of instability. And this is where SINS came in. And so SINS is a tool that's important to say, like, look, this person may need surgery. So we look at location, mechanical pain, lytic tumor, what the alignment is there baseline collapse, is there posterior lateral involvement? And what's important is you need both. You need the MRI and you need a CT in order to do this properly. But you know that the ones that are unstable, you better call your surgeon. But this potentially unstable, we're still not sure. We have a discussion. But can this tool predict fracture? And this is work that I did many years ago where we looked at the individual elements and we said, can we use this as the easy way to predict fracture? So if you have baseline fracture, malalignment like kyphotic deformity, lytic tumor, and if you blast it with high dose per fraction, you're going to increase this person's risk of fracture significantly. And this is where you have to understand what those predictors are. Now with dose, this is where we get back to some of those concepts. So if you go 24 and 1, 40% risk of fracture, 20 to 23 in one fraction, you're at 20%. And then under 19 gray, you got 10%. And that's what the data show. And that's why I can tell you that I don't know if you really, there's a difference between 28 and 2 or 30 and 4, because you've kept that dose per fraction lower. And our data don't support that there is. There may be added benefits in terms of fibrosis of the skin or peripheral neuropathies that are associated with more fractionated regimens, but not necessarily fracture. And fracture can happen acutely, and it can happen in a late fashion associated with necrosis. So these are just those data in terms of refining the risk. So this is based on 1,400 vertebral metastases. We put all the data into machine learning, and this is what came out. So we found that our normal risk factors are there, but not the dose per fraction, because we uniformly are under 19 gray per fraction anyway. We never go higher. So we're learning more and more about how to refine the risk and automate a lot of the risk factors as we do more AI ML. Okay, so let's get to our next MCQ. Which factors are clear predictors of spine SBRT-induced fracture? Baseline fracture, lytic disease, 24-1, or all of the above? So we'll just give some time. You should have some Jeopardy music. All right, we're getting there. 65%.
Yeah, almost there, almost there. So few more votes. Okay, great. And in the poll, sharing results, majority answered all of the above.
Beautiful, beautiful, beautiful. All right. Now, we're going to get into some of the rare issues also, including plexopathy, okay? And this is where we started to notice this over time. So we looked at our data because this is a late effect, okay? So in our cohort that survived more than 3 years after SBRT, what we saw is that that fracture risk is about 10%. It increases slowly over time as you get more smoldering necrosis, weakening the bone, but your neuropathy rates go up. And these are brachial plexus or lumbar sacral plexus. Now, what it tends to be are people that are heavily radiated. So it's still rare in someone with one course of SBRT, but we do have to respect this risk. And it's 5% at 5 years and 3% at 3 years. So what do we do? Well, nobody really knows. So I'll show you how we've changed our practice. And I talked to everybody, kind of around the world, said like, what do we do? So this is what we would normally do, 28 and 2, not spare the nerve root. And now we draw them and we say, okay, when we're going to high doses like 28, we limit it to the prescription dose. But when we do our low dose of 24, we just say no hotspot. And this is pretty much what most places are doing. So what does it do to the dose distribution? Well, it breaks it up, okay? You want to make sure you're covering by at least your minimum dose. Like we know 24 and 2 works, so it can break up, but we make sure our coverage and where our isodose lines are at least by the 24. So you don't want to be too broken up, okay? So you got to make sure you have the wash in your target, but limit your nerve root to no more than 100%. And this is what we're doing now, and anecdotally, it keeps going good. Now, other areas that you also have to be aware of is the esophagus. And we don't talk that much about it, but these toxicities happen. And you got to look at the isodose lines because we do have max 2C, C, and 5cc dose limits. But look at this dose distribution. We meet the criteria. I say, great. But I'm like, look, why am I covering by 20? Push it down. So again, all my numbers are met, but I like this gradient better, but I don't like the 1500. Push it down. So what's the trade-off? Well, you're going to get more dose posteriorly, and it's okay, because we don't want to cause esophageal complications. So look at the dose distribution. This is very important, slice by slice, and pay attention where your gradients are, because you've got your central gradient, that's fine, but you also have to look at your gradient with the esophagus or bowel. So overall, I would say spine SBRT is now recognized by many international consensus or organizations and guidelines, and it's here to stay. So you can really help your patients. But where we're not so sure is in the non-spine bone meds. And this is where it's different. We don't equate spine and non-spine together. And I'll briefly go over this in the sense that these bones are different and it's everywhere, right? You can go from here, the pubis to the rib. And ultimately, we do treat these patients with SBRT, but are we doing the good thing? So what are our data? So these are some work that we did many years ago, 106 bone mets treated with 5 fractions, and that's what we pretty much do. That's what most people do around the world because you're not going to take risks, and we don't know if we're doing better. So our data were 5% local failure rate at 6 months, 13% at 2 years, 9% risk of fracture. So we're feeling pretty good. We've updated these data to 500 non-spine bone mets. And what we found again is our cumulative incidence of local failure, 12% at 2 years. Our median overall survival, these are oligometastatic, they're living a long time, and pathological fracture in 12%. Cumulative incidence of fracture kind of slowly increases, over time. So we're happy with the numbers. We like what we're doing, and we're showing efficacy. Now, are all bones the same? And so the majority of these data really are like rib or pelvis. But what about the long bones? And that's where the details come in, because a lot of times you look at a femur, look, I don't feel that comfortable doing femur or a humerus, right? And so we actually put our data together, and amongst all these high volume sites, we only had 114 long bone mets, but we showed good results in terms of risk of fracture. Local failure rates were low. Extra osseous extension predicted for fracture and local failure. So, some data, but I'm cautious. So this is a patient, here's your GTV. We apply a 5mm CTV and take the entire radius of the bone at risk, but 5mm craniocaudal, treated it with 30 and 5, and lo and behold, here's the fracture, right? So you just got to be careful, and we have to have good data before we go prime time. So what are those data? So we do have a study from MD Anderson, randomized phase 2, and it's a good trial. I mean, it's 12 or 16 gray in 1 versus 30 and 10. They did show, I think, as proof of principle, potential for increased improvement in pain response by about 20%, okay? And they had low rates of failure. So good data, randomized, and supports the theory. Then we have the RoboMet study. So again, randomized controlled trial, 126 patients, spine, non-spine. And they did have quite a bit of non-spine in the sense of long bones, pelvic bones, thoracic bones. And they showed on the intent to treat analysis a significant improvement in pain response at 3 months. So good data. There's some controversy, but I like it. And on the they didn't get it in terms of their intent to treat, but they did get it on the per patient treated. So again, complete response rates seem to be better. Good data. Okay. So let's get to our MCQ. The level of evidence that supports superiority for SBRT versus conventional external beam radiotherapy for non-spine bone mets is based on level 1, phase 3, level 2, phase 2 RCT, level 3 prospective non-randomized, or none of the above. And RoboMet was a phase 2.
Okay, almost there. Few more answers. Okay, great. Ending the poll, sharing results. Most people answered level 3.
Okay, good. Yeah, no, so we do have phase 2 randomized. So the MD Anderson study was phase 2 randomized, and so was RoboMet. So a
RoboMet.
little bit better. Okay. So how do you dose? And this is a lot of the questions. So we've done a little bit of work in terms of number of fractions. We went around the world, asked them, and you can see the majority of people use 5 fractions. Sometimes, there are different considerations in terms of dialing it down or dialing it up. We don't know. And this basically shows you there's a lot of heterogeneity in practice. Now, how do you plan? So there's CT and MR, like spine is an MR planning. So we did some work with MR versus CT planning. And we routinely do MR planning for you need both for non-spine. And what we showed was that the T1, so if you have at least the T1, you'll have better agreement in the GTV as compared to what a radiologist would contour. So there is some added benefit. We didn't really find a benefit on the T2, but the T1 certainly did. So in terms of the principles of contouring, so again, we went and we did a analysis, and we asked all these people to draw them. And what we found was that the majority of practitioners do use a margin, intraosseous margin of 5 to 10 millimeters, extraosseous margin of 5 to 10 millimeters on the extraosseous disease, and respect anatomic barriers. So there's some variability, but overall pretty good. So GTV, 5 millimeter, CTV, take the anatomy at risk as well. And respect the anatomic boundaries like the SI joint. So in terms of the technical approach, Renee will talk about this, but it's not as robust. I think that's what the point here is. You don't have to do it like you do spine. You don't necessarily have to do MR planning, but because we don't have the data, but you have to know what you're doing, and it's a lot more generous. Okay, so let's get to our MCQ. So the risk of fracture for non-spine bone mets: 5%, 10%, 20%, 0%.
I think non-spine would be a good way to start for Ukrainians for the sites that don't do any SBRT in the clinic, right? So that would be the obvious choice.
I think it's a good way to start. I mean, and then as you build your experience and your comfort, move to spine because it's higher risk, and you need more resources. Okay, so 10%, absolutely right.
Great.
Okay, so this leads us to now the SC29 study. So this is a Canadian randomized trial that started, and we're basically doing it like SC24, randomizing to 20 and 5 versus 30 or 35 gray and 5 fractions. And because the majority of the world is 5 fractions at the end of the day. And we're building in our predictors, so we would exclude radiosensitive. You have to have a minimum score of 2 to determine response, but we're stratifying based on extraosseous disease, known predictor, and we changed it based on radiosensitive being breast and hormone-sensitive prostate versus all other, and then pelvis versus non-pelvis, because the majority of it is pelvis. And then we'll see how it goes. 230 patients, we just opened, and we're looking forward to these results in a few years. So in conclusion, I'd say spine SBRT is now established a field with great promise. Clinical practice is evidence-based. We have a positive level 1 evidence study to support it. 24 and 2 is a good palliative regimen. If you need to push it, go to 28 and 2. Fractures are still an important area of research. And we need a randomized study for non-spine bone mets, and we have one. And we have to be sure what we're doing is truly helpful. And now that I'd say thank you very much.
Oh, thank you. That was an excellent lecture. You flew through it. It was very, very great overview and so much work done by you and the team. That's incredible. So we have a question already in the chat. So I would encourage everyone to please ask question now because Dr. Saghal would need to leave. So Dr. Burik asked a question. Dear Dr. Saghal, thank you so much for excellent foundational lecture on SBRT for non-spine bone and for spine SBRT, especially your discussion vertebral metastases, epidural metastatic disease. I would like to step slightly beyond today's scope and ask about relatively rare application of SBRT to spinal cord tumors. Question 1, which hypofractionation schedules and planning dose constraints do you recommend for intramedullary spinal cord tumors, metastases, ependymomas, astrocytomas?
Okay, so it's a good question. So I would say that, for us, we don't do it, for primary spinal cord tumors because we don't have the evidence. And so we use still traditional 54 and 30. I think for intramedullary metastases, if you wanted to, you could probably go to 25 and 5. the issue is the majority of patients die within 3 months when it goes intramedullary. So, you have to ask yourself, what are you doing? If it's oligometastatic and maybe they're going to target it, I think 25 and 5 is pretty safe, but you don't want to take further risk because these patients are quite sick. If you're going to do primary spinal cord tumors, ependymomas, astrocytomas, you are going outside of the evidence. And we can't do that. We're an evidence-based practice. I don't know what the long-term efficacy is. Unless there was a trial, I wouldn't do it. Now, there are some other diseases that we do, and you can take that knowledge that we have in the cranium and apply it to the spine. For example, neurofibromas, meningiomas.
Right.
You know what that is, and you can give 25 and 5, and we have data. Laura Faracelli's group did a very good job at 25 and 5 for meningioma, and I routinely give that in spinal cord meningiomas. Now, for spinal canal schwannomas, you got to be a bit careful because you can cause pseudoprogression. And we don't know whether or not pseudoprogression is greater with hypofractionation versus fully fractionated. It's probably a little bit higher, but we don't know. But you just got to be careful, okay? Because if they swell and they go into cord comp, then they go to surgery. But I've done it, and I give 25 and 5, but I give it on a Linac because I would say that I'm not sure if the heterogeneity of the dose distribution impacts that risk of pseudoprogression, and I worry. With a Linac, it's nice and flat and homogeneous, right? Now, the issue that you have to be aware of if you're going to do it is minimum field size, because sometimes these are very small, and so you have to know what kind of minimum field size you're dealing with. Larger ones, it's different, but you have to know your technology. Now, other areas where we do it, hemangiomas, so vertebral hemangiomas, and I give 24 and 2, and it's like a bone tumor. But I've had good results with 24 and 2. Some people give 25 and 5, either way. But you just have to be careful with primary tumors.
Okay, excellent. A second question for extramedullary spinal cord tumors, NF2, what dose fractionation do you use? Which spinal cord PRV constraints guide do you practice?
Yeah, so these patients are going to live, right? So same similar thing, 25 and 5. I
Okay.
don't think you need more than 25 and 5 for any benign tumor in the central nervous system. There's no need to give 30. Now, atypical meningiomas are different, because there we go to 35 and 5. You have to give more dose. But grade 1s, it's all the same, 25 and 5. Easy, safe, you're not going to hurt anybody, but you do need the drop off in the dose distribution because you're exposing the cord. So you do be mindful that you do want partial volume exposure, not homogeneous exposure.
And we will hear it from Renee and also Saher about technology you're using, but maybe you tell us now, what do you usually use? Linac? Linac
Yeah.
based?
We use Linac. We're all Linac based. I mean, for the brain, we have a Gamma knife,
Okay.
but for everything else, it's all Linac based, image guided, and we're.
And so there was a nice overview of non-spine SBRT, right? And there's like a recommendation to provide a margin CT. Do you do that in your practice routinely?
Yeah, we wrote the guideline. So
Right.
so we wrote it. And so that's
We
where
don't
we.
always do it at Stanford.
Yeah.
Yeah,
Sometimes, some people do, sometimes don't, but that's something that we're gonna have to validate at some point.
right,
But a 5 millimeter margin, look, I'll tell you, you don't know where the GTV is. It doesn't matter what you say, anybody, you don't.
right.
And there's no test. I mean, if you're putting in PETs and MR and put everything together and spending $1 million just to figure that out, then maybe you can, but otherwise you don't know. So what's wrong with a 5 millimeter margin?
Right. Especially if there's nothing adjacent to it, right? So
Yeah.
you're not
And
risking
especially if you're in
anything.
a long bone, right? The
Right.
cranial will extend, and you don't want to fail.
That's right. Okay, there's another question from Dr. Burek. Does spinal instrumentation change your SBRT approach for vertebral mats, planning dose fractionation constraints or target definition?
Yeah, so it's a great question. So it doesn't change any of our approach in terms of constraints or how we plan, because we know that the titanium really doesn't do much in terms of the dose distribution. As long as you're using IMRT or VMAT, it all washes out. There's some minor changes. We've done phantom work many years ago. You know, this issue of using carbon fiber would be great if we could do it. I mean, it's radiolucent. There may be some dosimetric effects, but they'll be minor. But the fact that you can see things better is huge, you know.
Hmm.
But it's an expensive thing that we can't necessarily get, at least in Canada. Um, but where we do deal with the contouring. So there are
Right.
guidelines which we've done for post-op, and you got to be generous. There are two important things. The majority of the time we take a donut, so we just treat the entire volume because you don't want to fail after surgery. And there's nothing wrong with circumferential dose distributions. Absolutely nothing. You know, and what's important is you have to know where your preoperative extent of epidural disease was and make sure you cover that, because we've shown that that's the predictor of failure. It's not where
Hmm.
your postoperative epidural disease, it's where your pre-op. So if it was extending a lot craniocaudally, you got to make sure that you take that spinal canal craniocaudally, not necessarily the bone, but cover where that is. So it's in some ways it's a bit more complicated to draw. In other ways, it's a lot easier.
Yeah. Okay. Thank you so much. Thank you. That's great. So I will be playing the presentation from Saher now. Thank you. Do you have to leave now, Dr. Sagal?
I'll wait a few minutes.
Okay, great. Thank you. So I'm gonna share.
Hello, my name is Saher Ali, and I am a clinical specialist radiation therapist. My role includes oversight of the SBRT program here at Sunnybrook. I'm sorry I was unable to be with you in person today, but I thank the organizers for the opportunity to present a recorded lecture. Today, I'm going to be speaking to you about the radiation therapist's perspective on treating spine and non-spine bone targets with the SBRT technique. I'll discuss immobilization, some of the technical aspects of CT and MR simulation, and lastly, cover our image guidance or IGRT protocol. Due to the precise nature of SBRT, immobilization is a critical component to ensure accurate and reproducible setups. Starting with upper spine, which includes the C-spine and T-spine between T1 and 4, we recommend the use of a 5-point mask with a second layer of reinforcement material that covers the patient's head, shoulders, and mid-sternum. Patients should remove clothing from the upper arms, shoulders, and chest to allow the mask to be formed over bare skin. Shaping the mask well to create a tight fit and prevent gaps under the chin, the sides of the neck, tops of the shoulders, and avoid cutting out eyes, nose, or mouth, as this may impact the stability and integrity of the mask. Spine patients being treated to targets inferior to T5 should be immobilized in a full-length evacuated cushion that is indexed to the bed. Patients can be positioned with their arms above their heads or by sides, whichever is most comfortable for the patient. The evacuated cushion or vac lock should be formed tightly around the patient to limit motion and rotations. The final step to ensure near rigid immobilization is the application of the top sheet and vacuum compression over the entire body. The full body vac lock setup can be difficult for patients with significant pain or mobility issues. Here are some alternative methods of immobilization that can be used. Half-length vac lock with or without vacuum compression can be easier for patients to climb in and out of. A 5-point mask with indexed leg supports or a body mask are options for patients that may require staff to lift the patient or do a slide transfer onto the treatment couch. Anytime alternate immobilization is used, consult with the physician, physics, and dosimetry, as this may require adjustments to planning margins, dose fractionation, and IGRT instructions to account for the decreased rigidity of these methods of immobilization. Immobilization for non-spine bone will vary significantly based on the area to be treated. Targets in the mid-thorax, such as anterior or lateral ribs, can be immobilized with arms raised overhead on indexed equipment and have breathing motion management using abdominal compression or vacuum compression. Due to the proximity to the spine, posterior ribs should be immobilized similarly to spine SBRT, as was shown in the previous slide. Upper thorax targets, such as sternum, shoulder, proximal humerus, can be immobilized in the reinforced 5-point mask. Lastly, targets in the pelvis can be immobilized in indexed full or half-length evacuated cushions. Due to the stability of the pelvis, these sites do not require the addition of vacuum compression. Indexed body masks that cover pelvis, hips, and upper thighs are also options for this area. Now that the patient has been set up and the appropriate immobilization equipment made, let's move on to the details of simulation. Spine targets should be simulated in treatment position using a helical CT scan. 1 millimeter thin slices are recommended to allow precise fusion and target contouring. Non-spine bone targets can be scanned with the slightly thicker slices. Helical CT is sufficient for most bone targets. However, a 4D CT is recommended for bone targets in the thorax and abdomen that may move due to breathing. For both spine and non-spine bone, IV contrast for the CT scan is not required, but may occasionally be used in cases with soft tissue extension. Whether you have a dedicated in-house MR simulator or are reliant on diagnostic images, MR to aid contouring is strongly recommended due to its superior spinal cord visualization and improved soft tissue contrast. It allows more accurate delineation of the tumor volume, and lastly, it can mitigate the artifacts from implanted hardware that may obscure the spinal cord on the CT scan. Here are common MR sequences used to image spine and non-spine bone targets. Due to the limitation of MR scan length and field of view, it is important that physicians specify the exact location of the target in their orders or requisition for simulation. Ideally, MR scans should be acquired with the patient in the same treatment position and with the same immobilization equipment used in the CT. Upper spine cases can be MR'd with their mask and the same neck rest as CT to ensure similar rotations and extensions of the neck. Unfortunately, the full-length vac lock used on lower spine cases may not fit into the bore of the MR and may degrade the signal if used. These patients should be set up using tattoos and the same neck rest to best approximate their position on CT. And as the immobilization equipment used for non-spine bone cases can vary significantly, use that equipment whenever possible. This precise contouring of the targets, especially spine targets, relies on good quality image registration between the CT and MR. Here are some tips to use when performing fusions. Verify the level of the scans. MR datasets can be small and it may be difficult to localize the level superior to inferior. Locate T1 or T12 on the CT image set to help count vertebral body and use surrounding stable anatomic structures to orient yourself. Ensure the image is matched at the target level and one vertebral body superior and inferior. If the fusion is difficult, prioritize the match at the target level. Match the vertebral bodies and pay very close attention to the spinal canal. Use the spinous process to help visualize rotations that can be corrected. Some challenges you may encounter with fusions. If diagnostic MR images are used where the patient was not in treatment position, there may be significant misalignment that cannot be corrected. This is most commonly seen in the upper spine when the patient's head tilt and neck position is different. Long target volumes in the lower spine or long bones may have different rotations at different levels. And orthopedic hardware creates artifacts on both MR and CT, such as black voids on the MR and bright streaks on the CT. For these reasons, a second independent check of all fusions is an important step to consider incorporating into your department's workflow. My physics colleague Renee will be giving a more in-depth overview of dosimetry. But I wanted to stress the importance of coordinating isocenter placement, patient position, and immobilization equipment. Due to the indexed aspect of immobilization equipment, there is a risk of collisions on the treatment machines. Both simulator therapists and dosimetrists should be mindful of these collision and clearance issues to ensure patient safety. The final tool in the toolbox of precise SBRT is image guidance on the treatment machine. At Sunnybrook, all of our SBRT patients are treated on Linacs outfitted with a robotic couch top that allows for the patient position to be adjusted in 6 degrees, 3 transitional planes and 3 rotational planes. For spine SBRT, 6 degree of freedom corrections is strongly recommended. However, it may not be as necessary for non-spine bone. When 6 degrees of freedom is not used, PTV margins should be adjusted to account for daily setup variations, not corrected for by the bed. For spine SBRT, the CBCT match should be done to bone, ensuring alignment at the correct vertebral level and precise matching at the spinal canal. Non-spine bone cases are also image matched to bone, with additional consideration for the surrounding organs at risk. For example, the image on the left of the rib target has brachial plexus and spine nearby, whereas the image on the right of a pelvis target should be matched with attention to the position of the bowel and bladder. Establishing a clear workflow for IGRT is an important aspect of an SBRT program. We perform 2 cone beams at Sunnybrook. The first is the initial registration and a second CBCT after bed shifts have been applied to confirm the match and make any remaining minor corrections. When we first started our SBRT program, we required a physician or designate, such as an SBRT specialist therapist like myself, to review all day 1 CBCT matches prior to treatment delivery. This was an opportunity to identify challenging cases that needed patient-specific match instructions, and a chance for therapists to learn from the physician so they could reproduce the same high-quality match on subsequent days when the physician was not present. With staff education, a clear IGRT protocol, and years of experience, we have now eliminated the need for day one physician approval of the cone beam. IGRT for both spine and non-spine bone is now a purely therapist-driven process at our center. The setup and delivery of SBRT treatment can be quite long. Remember to assess the patient's condition prior to treatment. Pain, mobility issues, anxiety, and claustrophobia are all common concerns that may impact a patient's ability to stay still. Consult with the physician if medication may help the patient comply with the setup position. Again, I'm sorry I was unable to be there with you in person today, but please email me if you have any questions and I'll be happy to answer them. Thank you.
Thank you, Saher. That was excellent presentation. Just a question maybe to you, Renee. How long is the treatment? Saher mentioned that can be quite long. What's the average duration?
Yeah, so for non-spine bone, you're looking on the order of probably minutes, so it's not too bad. I guess for the spine SBRT, maybe like 10 minutes is
It's not
ballpark.
so bad.
It's not so bad.
Okay,
But
great.
I think it's more like setting the patient up can take,
Right.
in the body fix, it can take about 20 minutes. So
Right,
the entire time they're there and the robotic couch adds to the time. So it's not
Right.
necessarily the delivery time, the total time is long.
Okay, thank you. All right, Renee, it's your turn. Mind
Okay,
sharing?
you can see my screen there?
Yeah, perfect.
Okay, good evening, everyone. It's a pleasure to speak to you today. I'll be focusing on treatment planning and our experience over the years. The learning objectives are, how to do SBRT with conventional Linux, because that's what our experience base is. And obviously there's a lot of platforms that you can use for this, but we're going to focus on understanding the minimum requirements for doing this technique. And it's actually pretty nice that we're going to be speaking about or looking at spine and non-spine bone because they are quite different. There are some similarities, but the complexity varies. And then I'll talk about some practical considerations and things we have learned over the years. So I don't expect you to know the answer to this question. I just decided to add something a little bit based on history here. When was stereotactic radiation developed?
It's a good question.
I
I think
see some people have it right.
very few.
Yeah, I know, it is a tough one. I'll just give you another few seconds there.
Yeah. So let's see. Few more answers. All right, I'm ending the poll, sharing the results. Do you mind
Okay,
comment?
sure. So it was in 1948, so some time ago, and it was by Dr. Luxell, which was a neurosurgeon. And then in 1968 is when Gamma Knife was created. So it has been some time in terms of the technology being available. Just a little bit about our program. We started SBRT, I guess, 17 years ago now. And we started with a small number of patients, right? We started with lung and spine because Dr. Saghal had joined our group. He had an experience with that and helped us get that program going. And at the time, there was a fair bit of data on lung. So that was the next site that we started up. And then we slowly grew our program. I haven't even included everything we have here because there's also prostate, the non-spine bone nodes. So it really has grown over time. Okay, so in terms of treatment planning, you have to consider just in general contour accuracy. So you also want to be consistent in how you contour organs at risk in terms of supinfix stent, because you will be looking at volumetric constraints. You want to assess your margins, and if you're going to be using PRVs on some OARs, it's not mandatory, but it does help depending on how you do your planning. How are you going to deal with surgical hardware? As Dr. Saghal had illustrated, and I believe Saher as well, they quite often can have surgical hardware. So for us, we're using Pinnacle, and we know at what density the planning system no longer accounts for it. So we'll contour it and we'll do a density override to increase the accuracy of our dose calculation. Dose fall off. So in conventional treatment, it's not something that we look at, but in SBRT, it is more important to now track the conformity index as well as intermediate dose fall off. Isocenter placement is important both for image guidance, but we also have a rule in-house that you can only treat a volume if it fits within the field of view of our IGRT. And I know you're thinking SBRT is small volumes, but as our experience expanded, we do sometimes treat multi-lesions with a single isocenter. So that's usually where you would fall into that situation. And you also need to be mindful of the collisions that Saher mentioned, because we use a robotic couch that actually decreases our clearance as well. And we have an automated script that when we're doing our chart checks that will flag whether a mock setup should be done. So we have a pretty good sense of when we may run into collisions. You need increased dose accuracy. So the recommendation is to use a dose grid of less than 3 millimeters. Because we're still using Pinnacle and it can be quite slow, especially if you're doing VMAT, we actually use 2.5 millimeter. That was the happy medium. We did our own in-house assessment. But newer planning systems like RayStation, Eclipse, the default is 2 millimeters. So that's a non-issue for those systems. And then know the limitations of your planning system. So like I mentioned, for example, that the density saturates at a certain level, or maybe it doesn't take into account, changes in tissue density very well. And then just moving on here. And then you also want to, and you want for spine and other bone mets, there really isn't a need, I would say, for coplanar. It's not to say you can't do it, but I don't think it's really needed here. And then usually in terms of technique, at least the way we've approached it, we started with, what we were comfortable doing. So obviously we started this a long time ago. So we had 3D conformal and IMRT at that time. So those were the techniques that we started with. And then we slowly implemented VMAP and that became available, and then slowly brought on FFF when that came as well, right? So it was kind of like a sequential building. I would say for non-spine bone, you can absolutely get away with 3D conformal. They're pretty simple plans. For spine SBRT, given like you're dealing with modulation factors, I don't know, I would say on the order of 5, even up to 9 or 10 if it's a multi-target. So you really need to be at the minimum using IMRT there. So in terms of planning parameters, beam energy, we've always used 6. I'm sure some centers have used 10. There's pros and cons between using one over the other. If you are going to use 6 MV, your treatment times will be longer. So that's where you have to look at your total treatment time. If you're on the order of, let's say, if you're doing spine SBRT, and if by chance it ends up being on the order of 30 minutes, then you should do an intrafraction image guidance in there to decrease your margins. In terms of MLC size, honestly, as long as you have 5 millimeters, I don't think there's a lot of gains in going to anything smaller. I think you'd be challenged using 1 centimeter MLC for some of these smaller lesions. Although I have seen that done for, like lung SBRT, some larger lesions. And then you want to consider what kind of dose optimization engine you have. We're using Collapse Cone. We recently implemented Eclipse, so we have AAA. And then we're also implementing RayStation. So we're going to slowly be transitioning our program to those systems. You want to consider the CT slice thickness. So I would say less than or equal to 2 millimeters. more so because your targets are small, so that will improve your contouring of the targets. And then heterogeneity. So this is like it's just a different way of thinking, I guess. For conventional, we're always trying to make everything so homogeneous. And this is probably the one time, maybe less so for non-spine bone, where, you know, hotspots are considered good. And that's what's going to allow you to have the steep dose gradients. Okay, so going into non-spine bone, our experience, actually, I should just back up a bit here. So IMRT, normally we would actually use VMAT for these, but IMRT, this is an example and it's a recent case, we would use if the lesions are very small, just because we know in-house that our patient-specific QA has a higher chance of failing. And these are very simple plans, so we don't need to make it overly modulated with, you know, multi-arcs or anything. If you had multi-target single isocenter, that would be another case because you can do some sparing between the targets. And again, this is limitations of our current planning system. If our patient-specific QA fails, then we default to IMRT, basically because we can put a plan out much faster. And if for some reason the case was a rush, that would be another instance where we might default to IMRT. And we would use 6 to 9 beams, and we're using FFF. We try to rotate the collimator for the majority of them, and that helps with OAR sparing, but also interleaf leakage transmission, so that you're not circumferentially irradiating through certain OARs. Again, very simple plan. So this example, it's 6 beams and approximately 2 control points per beam. And these are just some of the parameters we put in there. And then let me just go to VMAT here. PTV margin, Dr. Saghal kind of alluded to it, but we do have a range and it depends obviously on immobilization and the way, you know, the CTB has been taken into account and so forth. So the majority of them are going to be 5 millimeter. But if they were in, you know, that full body fix, so we already have like the motion management for breathing and all these extra things, you can get away with 3 millimeters, but 5 millimeters is a great place to start. We would do a full arc unless the target is close to the anterior or laterally. So in this case, a partial arc was used. And again, the mindset, at least our experience here, is we just try to keep the plans as simple as possible. So this has less modulation. There's pros and cons to doing a full arc versus partial arc. We rotate the collimator again, so you're not getting circumferential irradiation through the leaves. We constrain the leaf motion so that the MLCs can't move too much between control points. And then these end up doing very well with our PSQA because there's very low modulation factor. So we come into this quite often, you know, multi-target. There's no way to have like a set rule, like distance between targets necessarily, where you kind of know whether to do a single or multi-ISO. It's just like a practical, you look at the case, if they're overlapping superior, inferiorly, and you can use the same cone beam matching criteria, then you can get away with a single ISO center. But if they were far apart, or if they're ranging between different areas within the body, then you may want to use multi-ISO, and I'll show you an example here. So this was an interesting one. It's a clinical case where my colleague and I disagreed. I'm like, oh, we can do that single ISO, no problem. And he was like, oh, definitely need 2 ISO centers. So as it turns out, they were able to do it with a single ISO center. These lesions are quite far apart. I wouldn't say it was the easiest. They did struggle a little bit with the setup. But another approach you could do if you're doing a single ISO center in a similar scenario is you could say, you know, target 1 is not close to anything, so we could put a slightly bigger margin on that and prioritize the match to the one you're worried about. That would be another approach as well.
Where did you put the ISO in this case?
I think it was in the middle somewhere
Middle.
here. Yeah.
And lateral, okay.
Yes. So we do have limitations with collisions. So we actually normally probably wouldn't move more than 8 centimeters laterally,
yeah.
ballpark, but This is just a snapshot of the dose constraints we would use for different fractionations. It doesn't show you like all the different areas. Just wanted to hone in showing that we divided our protocol into different areas to make it a little bit easier for the planners and sim staff and so forth. So we have pelvis, we have like basically extremities. I didn't include here, but there's like thoracic and then head and neck area. So we just did that for simplifying it for the staff and to have a shorter clinical goals list. If you included everything in your clinical goals, it'd be quite long. So coming back to plan evaluation, so the conformity index, we developed a lot of our own metrics in-house in terms of what we feel is achievable for us. So I would say most of the time we can get a CI for non-spine bone of less than 1.2. But if it was a really small volume or something, you know, more challenging, like sometimes you're treating like a prostate plus a bone met, then, you know, maybe 1.3 is more realistic. We also look at the intermediate dose gradient, the R50, and we based it on what, again, we could achieve in-house, looking at hundreds of plans, plotting it. But you could go to guidance documents, right? There's R2G and so forth to get values. And then the other thing to be mindful of is the location and size of the hotspot. So obviously you want the hotspot to be within the target, so you still visually have to go through your plan. Our non-spine bone tend to be still fairly homogeneous. Like you can see in this one, red is 100%, green is 95. So we don't even have really a 105 in this case. This is a small target. So it was pretty homogeneous. In terms of treatment delivery, these are all of our SBRTs are done on elective versas, and we do the KV cone beam, as Saher mentioned. We do 2 verification images. So one is you set up to tattoos, you apply the robotic shifts, and then we verify that the patient moved to the correct position. Part of that is we found, or at least this is our theory, is that sometimes the robotic couch is almost like patients not try to counter the motion, but I think they can feel the couch move. And so, and because we're using 1 millimeter, 1 degree across our entire SBRT program for simplicity, we found that we do need to do it. In terms of the bone IGRT protocol, Saher spoke to this. I just wanted to mention we have a single protocol that covers all the regions, and then there's just a section that will break out what they have to look for at the treatment unit, depending where you are in the body. Okay, moving on to spine. Okay, so this is just an example of, I guess, how we are able to use a 2 millimeter PTV margin, because it's pretty small. If you were just doing, you know, like a backlock like this here, you would probably be looking at on the order of, you know, 2.5 to 3 millimeter. If you then add the vacuum, so the patient, you know, minimizes breathing motion, they're really tucked in there well, and then that gets you down to 1.8, and then you add robotic couch on there, and that gets you down to about 1 millimeter. So it does have like a cumulative effect. So how do we do spine at our center? As Saher mentioned, the immobilization, we prescribe to PTV, 2 millimeter margin. We actually still do IMRT for all of these. We did work up a VMAT protocol, and it was just the computation time in our current system is so lengthy that it's just not worth it for us at the moment. But as we move to RayStation, it will be VMAT. So we typically use 9 to 11 coplanar beams, and I included our starting angles below here. We try to rotate the collimator to follow the spine, but it's okay to have a few that are at 0. And like I mentioned, they're highly modulated plans. The patients are treated daily, and they're on the robotic, and we use robotic couch correction. So our IMRT parameters, so the minimum segment MU is high because we're giving a high dose per fraction. But it's not uncommon to have, I guess, 80 to 100 control points for these. I'm not going to go into detail here. I just wanted to include a snapshot because I know having some of these dose metrics may be helpful for you when you start your programs. So I just included a snapshot here. And then as well as some of our OARs. And I just wanted to mention for nerve roots, this is just for the 24 gray, that 105. And as Dr. Saghal mentioned, if you go up to the 28, you limit it to the 28 gray. So let's go through an example because the planning of these is quite different. So we're going to have a cord PRV of 1.5 millimeters. And the way we plan will depend on the shape of the target. So whether, it's a C shape or wraps all the way around like a donut. The isocenter, we usually put it at the anterior part of the cord PRV because we're mindful of cone beam clearance and so forth. And then quite often we have to use what I call our dose sculptors. And that's just to try to push dose away from things. And we create an optimization structure to account for the fact that the dose gradient that we can achieve is 2 gray per millimeter. And I'll show you an example of what I mean by that. So here's a more straightforward case. It's a 28 gray and 2. This is a cord PRV limit. And I'll show you how we create the optimization PTV. So we just take the difference here. So we know what kind of gradient we're trying to create. So in this case, we would carve out 7 millimeters and optimize to this structure. And that should allow you to get the cord PRV dose that we're trying to achieve. So with spine SBRT, the difference is your target's going to get what it gets in terms of coverage. Right? We have to meet the cord dose. And I think that's just a very different way of thinking when you're planning these. Like you're going to have some dose
your number
spillage.
one priority is always cord, right?
Yes, or thecal sac, like whatever. It depends where you are in the body, but yes.
Mm-hmm.
So the plan evaluation for these, obviously we look at the PTV 100, but as Natalia showed based on our ProNo example there, it's not uncommon to have target coverage of only 80%. Like you should expect that. The optimization structure will be a little bit higher because that's carved away from your cord PRV to allow for the gradient. And then this is one case where I guess hot is good because that allows the dose fall off. So it's not uncommon to have a hot spot of, on the order of 140%. But we do still look at it. We don't let it just go to infinite numbers. For IGRT, so just coming back to when we started our program and we were using 6MV, so this is before FFF, it was still IMRT. Because our treatment times, and we were doing single fraction then too, our treatment times were very long, right? We were on the order by, I'm trying to remember a long time ago, probably 45 minutes. So we would actually do an intrafraction IGRT. And then to assess, we do this regardless. Anytime we implement a new immobilization, we will do a post-treatment IGRT to ensure that the patient is stable and that our margins are appropriate. So that's an easy thing that you could probably do as well as you implement the technology. So how precise are we in delivery? Dr. Saghal mentioned this one, the 1.2 millimeter and less than a degree. But the other one is if you're treating multiple vertebra with a single isocenter, if we're using, that full body fix, we're still like within 2 millimeter or 1 degree. So it's quite good. So we did not have to change our margins for multi-lesion. Another important thing to consider is patient-specific QA. Even though we've been doing this for 17 years, we still measure every single SBRT plan. We used to use ArcCheck, and now we're using EpiBeam, so we're transitioning. And now we've implemented an in-house AI program that will help, it basically takes in the beam parameters and makes an assessment of whether we need to do a measurement. But I do recommend, for I think I put here based on UK consensus guidelines, 10 plans, but I think you probably need a lot more than that for SBRT. And I would just do it until, you know, you're quite comfortable with your delivery. So minimum requirements, conventional LINAC, there's lots of guidance documents. This is just one. I did want to mention, let me just see here. Minimum number of cases. This was recommended by Estro. So 12 to 50, median of 20, right? If you don't do it frequently enough, I think the challenge is everybody sort of forgets some of the details. Another thing I wanted to mention is not in here. Something that we did probably for the first 10 years is we actually had special rounds just for all SBRT that included a multidisciplinary team. We learned from each other as we implemented new sites. And then we also QA'd every plan before the patient started treatment. And I found that was actually quite useful. There's a lot of useful discussion that came out of those. Take home message is SBRT is obviously a little bit more complex, right, than doing conventional. IGRT, very important. Patient comfort in whatever immobilization system you decide to choose also will, I guess, give you success. You want to make sure you have adequate resources, both in terms of, you know, are you going to have a backup machine that can treat these if one machine goes down? Do you have enough staff to implement this? Even like immobilization, like sometimes even now we will run out of those body fix vac locks, right? So it can be a little bit challenging. And then there's a culture of safety. So people just have to be comfortable to speak up if things are not working or if something doesn't go as planned. And something that we didn't do a long time ago was standardize. So little things, even nomenclature, right? As our team expanded, you know, GI might say lift kidney and you give it to a GU and they say kidney left, like just little things like that. And then even dose constraints, like I think maybe 5 years ago, I had to get all the groups together to harmonize where we were at because every site had kind of gone off on their little silo. So we just looked at our experience and we updated our numbers. And then consider where your program will be, you know, 10 years down the road and plan for it up front, right? You probably don't need every mobilization system out there. Start small, have 1 or 2 if you can, and then just see if that's sufficient. And then another thing we did, and it's partially probably because we're a large academic center, there's a lot of change here, both in technology. We're always updating our values based on experience. Is we've created a change log so that we could always go back and see when did we change it, why did we make that change? So there's a committee that reviews this. And then a reminder that when you're really rushed, that's usually when mistakes happen. So it's important to just take a step back sometimes. And this is the team that I worked with when we started our program. So it's a big group. So I just wanted to acknowledge all their help over the years. It's been great working with them. And I'll leave you with my email. So if you think of anything as you're starting up your programs, definitely feel free to connect and I'll try to help you the best I can.
Oh, great.
thank
Thank you
you.
so much. Thank you. That was excellent and really good points, especially the points about safety and the importance of communication, keeping the logs. That's really, really good idea. And also monitoring errors, right? Or near misses. That's very, very important. And then discussing them to prevent them in the future when you implement in such a, you know, high dose per fraction, right? That's very, very important. That's great. Thank you so much for a great lecture. I would like to open the floor for questions. So we have Victor asking questions.
Hey everyone, and thank you, Renee, for a great talk.
You're welcome.
I was wondering about that single ISO multi-mat case. So you transitioned by the time to ArcCheck, or did you how did you MRTQA? Because I'm just wondering whether it fit everything in the ArcCheck.
Yes, we did on ArcCheck.
Okay, so basically you would set a limit if it was farther apart and you would not be able to QA it, you'd probably do a 2 ISO, right?
Yes, but our limitation was more our cone beam field of view is only 20 centimeters on the Electa, so that's our limitation.
Got it. Thank you.
Do you add additional margin for PTV if you have multi mat and then you put ISO not inside the mat?
Typically, no. I will say for other sites, specifically like, actually, I shouldn't
Brain,
say that.
for
It
brain.
it depends. So if
Okay.
we have, it's more based on priority of what it's adjacent to. So if they're worried about, I don't know, we'll say like the cord dose, then you're gonna prioritize the one that's closest to the cord and maybe put a slightly larger margin on the one that is not close to anything that we're worried about. So in that sense, yes, but in general, just because we're doing multi-target with single ISO, we do not increase the margin.
Okay. Sounds good. Can you talk a little bit about increasing margins? Let's say if in Ukraine they do not have 60 couch, right?
Okay.
You
Yeah.
did some really good analysis and calculations. So what would be the increase for the margin?
Yeah, so in those cases, I would probably start with non-spine bone. That's going to be the easiest. Start with
Right.
5 millimeter PTV margin,
Mhm.
and then assess based on your image guidance how well you're doing.
Okay.
For spine, hard to say. You would probably be on the order of 3 millimeters off the top of my head. But I would start with the easier scenario like non-spine bone and then work your way up to doing the more complex treatments.
Sounds good. And your dose grid was 3 millimeters, right? As I
2.5
remember.
millimeters.
2.5 millimeters for spine also?
Yes.
Okay. And you cannot do smaller grid because of the calculation time and limitations?
Yes, if you put it down to 2 millimeter or 1 millimeter,
Yeah.
it's at a standstill basically.
Right.
Obviously, as we move to ray station, 2 millimeter, they'll compute in like, a minute and done, but
Yeah, we typically set it to small as a grid, like 1 millimeter or 1.5.
yeah.
But yeah,
But we did a dosimetric comparison. So we did, I can't remember how many patients we looked at, but we
yeah,
did apply a smaller dose grid, and that's where
right.
we came up with the 2.5 millimeter was the happy medium.
Okay. To compromise, I see.
Yeah.
So I have Nadia Honcharenko with the hand up.
Hello, can you hear
Hi.
me?
Yeah, we can
Yes.
hear you.
It was really great lecture. Thank you very much. I have a question. Do you treat all patients for non-spinal SBRT, or you use conventional too for these patients?
Oh,
In which cases you would use conventional instead of SBRT?
yeah. So I think it depends. Like they look at sort of, it's more of a clinical decision. So whether they think the patient will be stable for a significant amount of time, that there's enough, benefit there for the patient to do this. Otherwise, you would go to a palliative. Right.
So
These are usually like metastatic.
You have a lot of patients to SBRT.
Yes.
Non-spinal. And how many physicists did you add when you started this program?
So when we
patients?
started the program, there was only 3 of us. We checked all the charts, and then once the program grew to include GI and GU, and then the non-spine bone and nodes, then we had to open it up to our department, which is a team of approximately 18 physicists right now.
That's a big department.
Yeah.
How many machines do you have in Sunnybrook?
We have 13.
13. And they are all Varian or Electa?
So we're in a mix right now. So we
mix.
were Electa for a long time. We do have 1 MR Linac. We have 2 Halcyon units, and we're bringing on TrueBeam. So that'll be our next 2 machines.
And
Right.
in terms of like a percentage of patients treated with SBRT, or how would you approximate that?
I would say at least 20%, probably higher now.
Okay. Okay. That's great to hear.
Impressed. Thank you.
You're welcome.
Impressive. Okay, great. Any other questions from the audience? Okay, if there are no questions, I would like to show you the case that Renee helped us um, provide for you as the homework. So I will share the screen. So Prono was kindly provided to us by Rise Contra Cancer. So I sent you recently the instructions how to log in and get the account if you don't have one. The workspace is SBRT Ukraine, and there are a few patients already in this workspace. So the one that we will be doing the homework on is SBRT Bone, Lecture 5. So that's the case provided by Renee. So you can open the case by double-clicking. You can have a look at, for example, structures. So it loads for us. I also uploaded in the notes the vignette that Renee kindly provided to us. So this is description of the patient and what we are treating. We're treating T2, so that's a spine SBRT case. So what you can do here, you can practice contouring. If you want to try to contour in this workspace, you can, and I'll send you instruction of exactly how to do this. So there are some of the structure sets that are empty that are created for you, and you can contour the targets, CTV, PTV, and also OARs like cord, nerve roots, esophagus, lungs, and trachea. So you can practice this and compare to the gold standard. I called it gold standard contours from Sunnybrook. And then you can also practice planning. For that, you would have to download this case by clicking Actions and Download. And you can import it into your treatment planning system, create the plan using the constraints that Renee provided to us. And then you can, if you want to score this plan, you can upload this back into this workspace, and you could see how well you did in hitting the targets. So you could see the scorecard for Renee's plan here. I will send you the detailed instructions for this. I think it's a great way for you to practice. And thank you so much, Renee, for giving us this opportunity and submitting the case. So it's really nice first teaching case. Thank you.
Thank you.
If there are no more questions to Renee, we'll just say thank you so much. It was an amazing lecture. It was really great. We learned a lot. And thank you for this great effort, and thank you for supporting Ukraine. See you next week.
Bye.
Bye, everyone.
Thank you. Bye.
Bye. Thank you.